All right, good morning, everybody, both in person and online. Thank you, Dr. Baptiste Roberts, for that amazing talk and for giving us a lens on this data and this problem and how we can move forward our pathways, and also giving us a reminder of the community that surrounds us and supports us both during pregnancy and beyond. My name is Nina Martin. I'm with the Maryland Department of Health, and it's my great pleasure to introduce our next speaker, Tanay Lynn Harris. So Tanay is the director and co-founder of the Bloom Collective, a reproductive and perinatal space providing holistic services and support in the greater Baltimore area. She's a certified lactation specialist, certified perinatal educator with Common Sense Childbirth Institute, and a postnatal doula trained with Abuela Doulas in the United Kingdom. She's a community-centered researcher and ethnographer focused on Black maternal health, transnational reproduction, abolition, and human rights. Tanay has worked with various national and international human rights and racial justice institutions over the past 18 years, including the NAACP Legal Defense and Educational Fund. She's an advisory board member of Collectively, a kindred partner with the Black Mamas Matter Alliance, and a co-chair of the Maryland Maternal Health Task Force. Tanay, I'd like to welcome you.
Good morning, everyone. I was definitely sitting there. I was like, no, Nina, I got 10 more minutes. They said 9:30. All right, I'm gonna try to. Oh, no. All right. So as Nina has shared, my name is Tanay Lynn Harris. I am the co-founder and director of the Bloom Collective. We are a Black women-led, community-based organization right on Greenmount, right off of North Ave. We started in 2018, really where we were all utilizing one another, and we really wanted to figure out how we could do this collectively, collaboratively, and so that we can really make some transformative change. And so it's important that we are just one community entity, one group doing amazing things in Baltimore and throughout the state of Maryland and even beyond. Okay. Now the autonomy me was like, I was gonna have full control over this. So I thought I was gonna be moving around with you all, but that's all right. We'll make it happen. So my presentation is called The Constellation of Care and Maternal Health. I do also want to make a note that although we are here talking about maternal health and my presentation states maternal health, that I am very, very actively aware and that we all should acknowledge the fact that not all pregnant people identify as mothers. And so all of the work that we need to be doing. And so sometimes you'll hear me interchangeably saying perinatal and maternal, but really realizing that there is a lot of work that we have to continue to do to support and to honor our trans and gender nonconforming folks. So my positionality, I am a Black woman. I'm a Black woman whose roots lie in South Carolina and Tennessee. I also spent most of my summers in Macon, Georgia with my mother. My family also migrated to Pennsylvania, primarily in Lancaster and Columbia. I'm a descendant of enslaved people who mostly come from West Africa. I'm the daughter of Alicia, the granddaughter of Loretta May and William, the great-granddaughter of Catherine, Dolly May, and Booker T, and the great-great-granddaughter of Elias and Percy, and also my great-great-grandmother, who was a grand midwife in Seneca, South Carolina, who was also enslaved. It is in their honor and memory that I carry their lived experiences and stories along with me. They are farmers, they were midwives, they were domestic workers, they worked on the railroads, cleaning them, and they continue to do that work all the time. I am a mama who has birthed a son. I have had 2 pregnancies. I am also honored to be a bonus parent in the lives of a 22-year-old, 17-year-old, and 12-year-old. Got a lot of questions about my decisions. I am a birth keeper, reproductive justice, reproductive practitioner, educator, ethnographer, organizer, abolitionist. I have worked on the legal defense of Black folks who have found themselves persecuted by a system that has treated them like they are disposable. My work focuses on Black women, people's liberation stories, collective care as a praxis, transnational reproduction, reproductive justice, Black womanhood, lactation, and perinatal health. All right, so we gonna talk. This ain't just about me, it's about all of us. And so I really would love to hear from you all. What would you like to see happen to ensure transformation in maternal and perinatal health? Everybody. Leah?
A focus on the first 42 days and 12 months after birth for postpartum care.
Okay, thank you.
An integration of mental health as physical health and also a driver of cardiovascular issues and other things in our data. Thanks.
Equity.
Mhm. Mhm.
Increased access to out-of-hospital birth, including a birth center in Maryland.
Mm. Mhm.
I'd like to focus on, I'd like to have us focus on having women be healthy before they become pregnant.
Mhm.
I think we spend, I'm very much, I'm a public health person, so I'm into prevention. And we're in a medical model, and unfortunately, I'm not sure that's helping us. So my vision is of healthy women having healthy pregnancies and healthy children.
I'd like to see breakdowns of silos of all the different systems of care and more invitation of community folks at the table to help lead the services that are being provided.
overcoming barriers to accessing postpartum resources, even within the community.
Mhm. Mhm.
I'd like to see increased accountability for outcomes, including financial policies, tied to income, bonuses.
Okay.
I'd like to see recruitment of providers to rural areas and areas where folks are geographically disadvantaged, such as the Eastern Shore,
Mhm.
and allocation of resources to those areas so that women who need higher level of care are not separated by a body of water and dependent on weather and other things to get them to the care that they need.
Right, thank you.
I know it's behind you. I would like to see two things. So I would like to see more providers offer fourth trimester care because that's lacking. And I also would like to see more two-generational programming because again, like we recognize that families are more expansive than the first generation or the immediate generation, but more programs that actually focus on grandmothers and great grandmothers and include them into the perinatal period, but also early childhood.
Okay, thank you.
I have a few. So education on birth spacing, more education about birth spacing, education with our young moms when it comes to sexual health. Also education or more advocacy with providers, giving them more detailed information during their appointments. I have too many clients where they're not aware of what's going on. It's a quick conversation. They do a little blood test and then that's it. They don't really get the explanation that they need. So more education and detailed info.
You last.
Yes, thank you. I would like to see providers take some of the trainings and attend some of the workshops and webinars that we attend, because as a CHW being, having my feet on the ground, listening to the diverse population speak about the unfairness when it comes to going to their appointment, being ashamed to disclose some of the things that they've dealt with and have their provider to actually say things that are insensitive. It's amazing. So cultural sensitivity training for all.
Thank you. So it goes to share the collective knowledge that's in the room. I'm just highlighting this picture, as Nina has stated, I am one of the kindred partners of the Black Mamas Matter Alliance. So did anyone celebrate Black Maternal Health Week? All right, so history lesson, 2017 at the Let's Talk About Sex Conference in New Orleans. There's about 25 of us came into the room. We were like, we have to do something to amplify and let folks know the amazing work that's happening. It's important to know Black Maternal Health Week is not solely talking about why Black folks are dying. It is really to do a celebration and an honoring of the work that we have been doing, right? Because you see, I told you my great-great-grandmother was a granny midwife, right? And so this carries on from Africa and indigenous perspectives. And so this is just a small cadre that makes up the collective, but there are lots of other amazing folks who are not pictured, but who continue to do that work every day in their own locales. And so I really want to uplift when we talk about community-based work, that no matter where we find ourselves, there are people in their own communities doing that work. The only thing that we should be doing is how can we support? Not how are we coming in, not how are we taking over, but how can we support? Social media is a thing. Sometimes we think if someone doesn't have a big, bright website, or if we don't see high algorithms, we think that they don't exist. So we should never be parachuting into anyone's community. We should only be saying, again, how can we support? How can I lend a hand? And that be that, right? So I want to start, have anyone heard of the Lucy Betsy Monument that's in Montgomery, Alabama? Has anyone been there? Okay. So this is Michelle Browder, whose family has done amazing civil rights and human rights work in Montgomery, but she is the artist who created this monument. This monument is now situated on land to honor the mothers of gynecology, which is in Lucy and Betsy. So a lot of times folks want to over talk about J. Marion Sims and call him the father of gynecology. But if he wasn't studying and mutilating these Black women's body, you would not have what you understand of gynecology, obstetricism, right, as to present day. And so we have to be able to really honor that and to locate that. When we talk about reclamation, another amazing thing is that the office where J. Marion Sims had brutally experimented on these Black women's bodies, she brought that office. And so now she is totally resituating that office. And I was like, girl, you sure you want to do this? But yes, there is something about reclamation. There's something about healing that's taking place. But I really wanted to center this, Justin, when we're thinking about the work that we do, how we do work in health systems, we have to really start thinking about the genealogy and the historiography of how it has come forth so that we can go back and really think about what has happened prior to, so that we don't replicate the same problematic and tragic and toxic behaviors, right? All right. So the 12 mothers of reproductive justice. A lot of folks like to say reproductive justice, but I got to let y'all know. It was 12 Black women, not women of color, Black women who were very proud. They were women, they were femme, who coined the term reproductive justice in 1994. When they had coined the term, they knew that coming together as a communal body of folks, that there are people all around the world who are thinking and ideating in the same way. They just coined the term, right? And so I do want to uplift Tony and Bon Leonard, Reverend Alma Crawford, Evelyn S. Field, Terry James, Basola Marginet, Cassandra McConnell, Cynthia Newbill, Loretta Ross, Elizabeth Terry, Abel Mabel Thomas, Wynette P. Willis, and Kim Youngblood. And so just so you remember, when you're saying reproductive justice, remember this. All right. There are lots of iterations around reproductive justice, but I'm going to uplift the one that a cadre of folks had pulled together in the article, Community Informed Models of Perinatal and Reproductive Health Services Provision, a justice-centered paradigm towards equity among Black birthing communities. And so every person has a right to decide if and when to become pregnant and to determine the optimal conditions under which they will birth with equitable access and utilization of culturally relevant options and opportunities for pregnancy, labor, birth, and postpartum. Every person has the right to prevent or end a pregnancy and can do so via options that are accessible, approachable, acceptable, available, and accommodating, affordable, and appropriate. Individuals have the right to parent children. They have with dignity and with the necessary social supports in safe, affordable, and sustainable environments and healthy, thriving communities without fear or threat of violence, intimidation, coercion, or control from individuals or the government. Individuals have the right to disassociate sex from reproduction, and that healthy sexuality and pleasure are essential components to whole and full human life. And what we oftentimes don't think about is that what really reproductive is really asking us is, how do we create the container for the right conditions to make reproductive justice viable, right? And so that means every single thing is a reproductive justice issue, everything. And so reproductive justice intersects housing justice, food sovereignty, health justice, mass incarceration, capital punishment, immigration, unemployment, underemployment, education, trans, queer, LGBTQI+ justice, environmental and disability, so many things, every single thing. So again, we have to ask the question every single day, is this creating the container to make reproductive justice viable? Are we creating the right conditions to make reproductive justice viable? Reproductive justice critiques systems of harm, oppression, and violence, literally anything that keeps us from living our most whole, fulfilled, and autonomous life. So let's pause and think about that. If we woke up every single day and said, are my clients, are my patients, are my community members, are my family, are they able to live their most full, fulfilled, whole, and autonomous life? No. And then what would happen if we asked that question every single day with intentionality? We will be actively working to make the types of change and transformations that are needed, right? I really like to uplift Dr. Bobby Harrell. Has anyone seen the psychosocialization before, utilized it? I come from the Black church. Y'all gonna have to talk to me. Yes, no, maybe. Okay. Oh, thank you. Look at that. Look at that. I thought I was up here by myself. All right. Psychosocialization. So at the core, there is fear, ignorance, confusion, insecurity. And at the beginning, that we are born into the world with mechanics in place. There's no blame, there's no consciousness, there's no guilt, no choice. There's limited information, no information, misinformation, biases, stereotypes, prejudices, history, habit, and tradition. Our first socializations that were taught on personal level by our parents, our relatives, teachers, people we love and trust, shapers of expectations, norms, values, roles, rules, models of way to be, and sources of dreams. And then it's reinforced and bombarded messages from institutions, churches, masjids, synagogues, schools, television, legal system, mental health, medicine, businesses, cultural practices, song lyrics, language, media, patterns of thought. It then makes manifest on it and enforced. It's enforced, it's sanctioned, it's stigmatized. There's rewards and there's punishments. There's privilege, there's persecution, there's discrimination, and there's empowerment, which then results in dissonance, silence, anger, dehumanization, guilt, collusion, ignorance, self-hatred, stress, lack of reality, horizontal violence, which is person-to-person violence, inconsistency, crime, internalization of patterns of power. So we have two choices. We either can take an action where we do nothing, we don't make any waves, we continue to promote the status quo, and we continue to go throughout this wheel, or we can have a direction for change where we raise our consciousness, we interrupt, we educate, we take a stand, we question, and we reframe. What I think is really important about this is that we are all socialized within the society in which we live in. We are all socialized within a patriarchal, white supremacist, racist, homophobic, transphobic, xenophobic, Islamophobic, all of the things, a violent society. And so regardless of that, we have to come from a waking position to be able to then make that change, right? So part of when we're thinking about socialization is the realization that any one of us could be causing harm, right? You could be Black, you could be brown, you could be white, you could be trans, you could be all the things, right? But if you are deeply rooted in your socialization and you don't do anything to make any type of change, you will and you can perpetuate the same particular harm. And so a lot of times when we're saying that we want to do things differently, we have to come from a waking position to say that, am I doing the work to subvert the same things that I'm trying to change, right? So a lot of times within clinical work, it's very linear. And holistic care asks us to be cyclical. How many of you all talk about the social determinants of health? You use it as a basis for your work. How many of you all talk about the structural determinants of health and use it as a basis for your work? Good, good, good. All right. So I think we have to think about the social and the structural. Social really casts blames on individuals of where they find themselves. And structural determinants of health help us get to the root cause as to why people are finding themselves in the particular positions that they are in. And if we are really being intentional about that, that would mean that we are really trying to get to the root cause of why anything exists, and we don't see people as disposable, and we do not blame them for the particular predicaments that they find themselves. So we have to look at the full constellation of care needed to prevent perinatal mortality and morbidity, but even more than preventing, we must be actively working towards liberatory futures where a holistic standard of care is normalized, which is about putting the whole person at the center. We have to get to the root cause of everything and acknowledge the full trajectory and life course of each person we serve and support. And so Jessica Roach, who was over restoring our own through transformation in Columbus, Ohio, years ago, created this theoretical framework that really looks at, you have to look at the whole entire system. We're right here in Baltimore, which is the epicenter of redlining, is it not? Right? So we have to look at how all of these things interconnect, right? So we're talking about, oh, someone is having issues along their pregnancy because they failed to eat. What happens if we change the conversation of what is it that they need to feel nourished and to feel whole and to have sustainable foods? It totally changes the trajectory where we're not putting the blame on any individual person. We're looking at the systems, we're looking at the structures, and then we're also looking at actionable steps to make sure that it's sustainable, right? So it also is something away thinking about like charity versus justice. And so charity is commendable, but it doesn't, like if someone wants food and we're saying, why do they always want food? We should really be saying is like, what can we do to ensure that they have the food that they need and they want without any of us being the middleman in between that, right? And so just really looking at this graph that really kind of highlights, we get increased maternal and infant mortality because of the root causes, right? Because of the systems and the structures. And so our role is to ensure, knowing this and coming from a waking position, is that we don't cast blames on individuals, that we cast blames. And that's for all of us, right? As someone who is a community-based practitioner, how do I ensure that I'm not looking at someone and blaming them and then causing further harm, right? Any thoughts, questions, or reflections from this?
The oppressed becoming the oppressor.
So I think really what we have to do is start thinking about how we rethink systems of harm and oppression. We a lot of times can be rooted in those systems and harm of oppression because we might not even know another way, but how can we continue to make some high level change and transformation? We really have to reflect on the violence that this society is built on. How many of us have talked about, how many of y'all before coming to Baltimore said something like, I don't want to go to Baltimore. Why they having it in Baltimore? It's a little violent in Baltimore. You ain't got to say nothing. I know some of y'all thought that. I already know. But the root cause has us really thinking about why there is violence. What's the violence that begets the violence? And we never really contend with that. So people are responding to the violence that is put onto them, that's projected onto them, right? And so it's violent that people are unemployed and underemployed. It's violent that we see dilapidated in buildings and blight. It is violent that children just last week in Baltimore had to go home because there wasn't no AC and it was 90 degrees. That's violence, right? It's violent that there is no nourishing food in the schools. We have to really start thinking about this. So when we're talking about the violence, we really have to start looking deeply reflective at ourselves, the systems and the structures, and how we're going to really work to make some high level change and transformation. And so the conditions are not conducive to reproductive justice, right? And so what we have to be thinking about are what are the right containers, again, to make reproductive justice viable in all of our communities. We always have to remember to challenge systems and structures and not individuals. It's easier sometimes to be like, we can sometimes just blame people for the plight they find themselves in, but we really have to start looking at the systems and structures. That don't mean there's gonna be a few folks in our family that's gonna get on our nerves. Like we tried and it just didn't happen. And then think about how might we perpetuate the harm we might attempt to subvert. So we might use words, those words sound cute, but what's your intentionality behind the words that you're using, right? People like to say equity, folks like to say justice, folks like to even say liberation. But are you living that out? Are you being intentional with that word? And as my grandma said, I don't make the news, I just report them. We have to create the otherwise possibilities, and as Dr. Ashon Crawley puts it, as the everyday practice to build the world anew, not as a destination, but something we can do every single day by even simply speaking to someone or thinking about how can I do something with a little bit more deep intentionality to really make reproductive justice viable. So patient-centered or person-centered. Who oftentimes uses, I do patient-centered care? Yeah, who often uses person-centered care? Okay. Patient-centered care, I think even with our great intentions, I think a lot of us are thinking about the person in that moment. But a lot of times in the clinical setting, patient-centered is essentially physician-centered model of care that prioritizes visits, disease management, coding, and reimbursements. And person-centered is a relationship-centered model of care that prioritizes patient and community knowledge, wisdom, and experiences over time with consideration of the conditions in which people live, work, play, worship, and partner. So it really is that a person is coming in, you're looking at the full constellation of who they are, right? And you are trying to meet them. It's not always about what is your blood pressure. It's not always about your BMI, but it really is, what do you need to thrive? What do you need to just be your best self? And so if we really start there, as opposed to all these other things, we're really getting to looking at the full constellation of the person. Bless you. So if we're thinking about some of the holistic care services, this is just like a small, it might look a little long, but there's so much more that could be added to this particular list. I would say from a Bloom perspective, if I have a person who is looking for services from Bloom, we know what we can do and what we do well. We also know that there are other amazing birth workers in our communities who can help support that. And in addition, they can say, I've been having pain in my back or in my hip, and I will recommend a chiropractor, pelvic floor therapist, somatic body work. I will also always, Kristen, perinatal mental health therapist, childbirth education classes. And so as someone who is a doula who believes in the work of doulas, we just also celebrated at the kickoff of Black Maternal Health Week was Black Doula Day, was that doulas can't do everything. We're just one part of the whole constellation of care. And so there has to be some intentional supports. One, who are those folks in community? So from a Bloom perspective, we talk to people, we get to know what is your ethos, are you in alignment, how do you do the care work that you say that you're doing? And then we will recommend folks, we'll create like a list of supports for them, which is considered like optimal care. And we also send folks out. So we do not believe that we can do everything in-house. That's actually a very, very toxic trait, right? To believe that every single thing that you can do is just only within you, as opposed to an entire community. That's really not a good thing. So a lot of times when we're talking to some of our colleagues who are OBs, we will say, it's like, what you all do is great. But when your clients go back to their communities, you would want to do some type of transfer of care back into their own communities. And so how do you do the work to find those folks, right? And the reality is that community relationship building, seeing each other, that don't cost nothing. So if you're serious about doing community-based work, it doesn't matter if you don't have any funding or anything. And this is coming from folks who are already under-resourced and underfunded. What we're saying is that you can do it. When you do the work in community, those relationships will continue to move, right? Here's just some photos of some of our work, but what I really wanted to share is like how we have hosted meetups and gatherings to be able to meet, how are midwives doing the work that they're doing, how are OBs doing the work that we're doing. Moving over to telehealth, supporting our lactation program, standing up for injustices, making some demands, being in right relationship, and connecting and building with each other. So also in 2017, when I said we got together and let's talk about sex conference, we also started the Black paper which is a holistic standard, setting the standard for a holistic care model for and with Black women. And so we put it as that it addresses gaps in care and ensures continuity of care, that it's affordable and accessible, it's confidential, safe, and trauma-informed. I just want to say this, okay? We got a lot of folks saying they trauma-informed. There's a lot of money for saying you trauma-informed. I met a hairstylist who said she was trauma-informed, and she got a grant for it. And the reality is that everyone will have some form of trauma. This isn't a minimizing trauma form. I just want us to be very intentional about the things that we're saying. Anyone can say that you're trauma forward, but how are you doing that work? How are you showing up? How are you making some particular changes in some ways, right? Again, we use a lot of words, and I will ask you, what you mean when you say that? So ensures informed consent, is Black mama family, parent-centered and patient-led, is culturally informed and includes traditional practices, is provided by culturally competent, humility, and culturally congruent providers, respects spirituality and spiritual health, honors and fosters resilience, includes the voices of Black mamas. And it is important when we do put Black mamas, there's an important piece to this that I think I just want to mention here. For us with the Black Mamas Matter lines, when we say Black mamas, we are acknowledging the fact of anyone, regardless if you have a child or not, anyone who loves, nurtures, or cares for his community, we're mentioning mamas here. We're talking about kind of like that, like wraparound supports. And part of the reason with kind of that duality of acknowledging gender expansiveness and trans folks is also we are living in a society that doesn't want Black mamas to exist. And so there's something about centering that and honoring that trajectory. Is responsive to the needs of all genders and family relationships and provides wraparound services and connections to social services. And you can all find this if you go to the Black Mamas Matter Alliance website. If you go underneath like resources and literature, it all shows up there. So we really try to sit on and stand on Ubuntu, which is a very interdependent way of being in relationship with one another, seeing each other, which really means I am because you are, and because you are, therefore I am. But even more than that, it's that a person is a person because of people, first and foremost. And so I think if we just pause just for a moment and really ask that question, like we talk about autonomy a lot, but do we really believe in it? And just to kind of think about that for a moment. When we think about the services, in my dream of dreams, I'm almost imagining we say to any client who might be on Medicaid, I'm talking to y'all, what are the 8 services that you need, want, or you desire to have optimal care? And they make the decision and they choose that, right? What would that look and feel like? And I know that you all are thinking through and doing that work, but what would that look like, right? Whatever constellation of care someone is saying, that we're not projecting it or putting onto someone, but we're actually saying your care is in your hands and they are being guided and facilitated with someone who loves and cares for them, whether that is a birth worker or a midwife or an OB who is really thinking about the constellation of care and really thinking about all of the amazing work that can be done. Any thoughts or reflections with that? Everyone like, yes? Thank y'all. So I did want to also uplift this. I think it's really important to think about a lot of what is happening that is causing harm. The reason also why I think about autonomy and I want us to be reflective of is just a few weeks ago, I had a client who wanted to have a vaginal birth after cesarean, a VBAC. And that was just deeply what she wanted. And we were like, we want to work with you to make that thing happen. But then her OB, who is lovely, OB was like, but I'm going on vacation. But actually didn't tell her that she was going on vacation, actually said, I want to do an induction. Now, for someone who wanted to have this VBAC, who already has had an extremely traumatic birth, that totally took away her autonomy. Because what happened is she started to think that there was something innately wrong with her body. And then who are the people who are right there by her side supporting her? The community folks, the community reproductive health practitioners, those of us who are already under-resourced and underfunded, her family and her kinfolk, right? And that takes a lot of time. It wasn't until 2 weeks later that her OB said, well, actually, I'm going to be going on vacation with my family and I really want to be there with you. But what if she would have said that from the very beginning, right? That then puts autonomy back into her hands. So something for us to really be thinking about. And so Dr. Tanay Davis, who is also a dear friend and colleague, had created or coined obstetric racism. And what she has done is also kind of created, if you haven't, it is in the Anthropology News, it's called A Birth Story. And so what she talks about are these layers that can happen that create obstetric racism. And the first is diagnostic lapse, when a clinician's uninterrogated belief that Blackness is pathological leads them to de-emphasize or exaggerate or ignore a patient's symptoms, resulting in an inappropriate or lapsed diagnosis. There's neglect, dismissiveness, or disrespect, when medical professionals ignore or dismiss a person's expressed need for reproductive help or care, and or treats them with disdain. Intentionally causes pain, when medical professionals fail to appropriately manage pain, which may be rooted in racialized beliefs about pain immunity, and as well as the absence of empathy for Black people's physical suffering, leading to lack of internal motivation to alleviate or reduce Black suffering. Coercion, when medical professionals perform procedures without consent and or intimidate patients to make decisions. Ceremonies of degradation, the ritualistic ways in which patients are humiliated or shamed, and includes a sense of being sized up to determine the worthiness of a patient or their support person who may be viewed as a threat. In response, medical staff may deploy security, police, social services, or psychiatric to ensure compliance or to remove the threatening person. Medical abuse can occur when medical professionals engage in experimentation and or repetitive behavior that is motivated not by concern for the patient, but serves to validate the clinician's self-worth and upholds their domination over the patient. And then racial reconnaissance describes the Herculean efforts made by Black women to avoid or mitigate racist encounters, included being hypervigilant about procedures. And so for any of us who work, whether you're a birth worker, you are OB, has anyone seen obstetric racism lived out? Right. Mentioning this is really for us to kind of sit and just to locate ourselves. Am I doing any of it? Am I a part of any of the problems? Again, not as a condemnation, but for us to be able to come from an awakening position, to be a part of the change and the transformation, to be the high, large arc of constellation of care that's needed. Any thoughts, questions, or reflections on this? Mm-hmm.
I was wondering, is there anything being done legislative addressing obstetric racism, especially violence, training, and awareness? Is anything done?
Mm-hmm. Really, really good question. She was asking, was there anything being done legislatively to address obstetric racism? And I think that in many parts, like all the different locales and states, I think there is an overstating of implicit bias. And I think we have to acknowledge it, but I think we have to get a little bit deeper as well. And I don't think that there's as much of an awareness that it is obstetric racism. And so I think right now is really kind of the awareness building that it is a thing and that it's happening, and for folks to be able to locate it. Yeah. Absolutely. So none of this is new. Right? Absolutely. I think what is happening is that folks are they're doing more of the intentional work of writing and also the reclamation of the writing, right? Because there are kind of the systems and the structures that when they're writing about it, it's more palatable and it doesn't get us to the root cause to be able to make the transformative change. And now you are seeing more intentional Black and brown and even white physicians who are really acknowledging that there's a huge problem, academicians and scholars who are really trying to stake claim and kind of put this back in. So really what is happening, like even for someone like Tanay Davis, who will always say like, I'm now a PhD, but I'm rooted in community, who's also a doula, who is a researcher and ethnographer. it's like, I only get this because I'm in community. I only understand this because I'm listening, right? And so I think that there's more of that kind of happening.
Thank you.
Thank you. Anyone else?
Thank you. Sorry, kind of in line of that same vein, I'm looking into like specific validated metrics and I found the PREM OB scale. And I was wondering if you could speak to that. And I know it was piloted at a hospital in Maryland. If you could speak to that or like the opportunity or just more awareness around what that entails.
Yeah. So only thing I can say is that the PREM-OB scale, which was created with Dr. Karen Scott, who creates it based upon these measures. And so she is finding measures, a way of how you can support or to do something differently. And so if you do want to learn more about that, I'll be honest, I don't know what Karen was doing with the hospitals, but if you do want to learn more, you can go to, it's Dr. Karen Scott, who is over birthing cultural rigor. And in November, it's either November or December, she will have the Obstetric Patient Safety Summit in Nashville. She had the first one in October, and there was a few folks from Maryland who were there. But if you go to that, it gives all the insights and the information there. Yeah, and she will be at our summit in October. So I really want us to kind of, I'm sorry, was there anyone else? Okay, sorry, I felt came back.
Thank you. I believe that anytime that, particularly in this country, because it is based on a capitalistic system, which is based in plantation mentality, I believe anytime that suffering is monetized, we're always going to get that. So I'm concerned about how we get the care to the people that need it outside of the capitalist medical complex, because this is killing people. And I don't think that people understand how detrimental this is, and the children born from this and the generational curses that follow this, because our suffering is continually monetized and often ignored.
Yeah. Thank you. I mean, I really don't think anything needs to be said, except for how do we convene space to address it, right? And then what is kind of the collective body of work to acknowledge that? Yeah, thank you for that. And there was some other hands, I saw them right here.
Thank you so much. Along those same lines, one of the things you were talking about is charity, right? And I think about grants, and we've been talking about the grants are, handed out, and then we give the services and then they're gone. And the way, and I don't mean to be negative, I love grants and of course I want them, but to be able to deliver the care. But again, thinking about how that perpetuates the issue with the underlying system, right? The fact that there is not equitable access to care, and that we're not working on how can we make Medicaid, right, just as equitable as private insurance is, right? And so instead we turn and we say, thank you for the grant, right? Thanks for the charity. And the system carries on.
Yeah, I mean, what was was it the group Ignite who wrote the book around the nonprofit industrial complex, and like a whole article on like granting, and I think that there's something, and it's not really, sometimes we go overuse innovation because really there's nothing new under the sun. We're just repurposing it in different ways. Sorry. But like there are organizations and institutions that are deeply rooted in their community. Like for Bloom, we're a hybrid model. So on one arm, we have an LLC, and then we're also fiscally sponsored. The reasoning for that is that we started with absolutely no money. And so it was, how do we do the work? And then we have a free to sliding scale model for all of the services that we do. So that becomes like, it's more communal centric. So we have people who give $5, $10, $20 that allows us to have some sustainability. And it helps us come from an awakened position that to not be heavily reliant on the grants, because you don't know what it's looking for. So we're really looking at a more sustainable liberatory model of what does that look like? And now a lot of times that's called social impact work. Or social enterprise. And so it's like, I think that there has to be some model. And to be totally honest, a lot of birth workers, because I do want to also acknowledge that a lot of birth workers do not identify as doulas because of the root of the word. And for those of you that don't know, a doula really in Greek means a female slave. So a lot of Black and brown folks do not like to say doula, but know that sometimes they have to. But there are birth workers who've always had sliding scale models for the work that they do. And they have just always been doing that work in their own communities. Yeah. There was somebody else. Yeah, sorry.
So one thing I just wanted to go back, well, something you mentioned and the person before you talked about, I think sometimes we forget that this is about people, like you said, and this is life or death for Black and brown people. And I think when we're saying what can we do, it feels like, you know, like we said about money and about, you know, how can I be better versus how can we make sure that these people stay alive? And I think if we take a step back and you mentioned Ubuntu, and that's something that I use with my students, and as an educator, understanding that everybody just wants to be seen as a human. And when we are in this world where Black people haven't been seen as human and other people of color, then it's easy to do this, right? To see the racism that's underlying that you're not really human. So, you know, you don't experience pain the same way we do, or whatever those, you know, the medical model has said about the differences in our biologies. And so I think that introspection you talked about, if we all just take a step back and think about what would I want my doctor to say to me? How would I want to be treated if it were me on the other side? And we take a step back from just seeing it as how can I be better for that person versus how can I be a better human to my fellow human.
Yeah.
So one of the things, you know, that I think we all can take away is to go back to the humanity of it all and recognize that we're trying to save lives. Like, this is life or death. I felt like, you know, I almost died. And so when I think about it, it really is an intentional space that we can be in terms of saving lives. And the only thing you have to do is see the other person as a human.
Yeah. You know, kind of in that efforts of like being culturally congruent or cultural humility is like to be in right relationship, like to be intentional or to come from a waking position is that you have sight. And the sight allows you to see the multifacetedness of someone, right? It's like a lot of time, no one in the Black community, to be honest with you, if you say postpartum, they be like, I ain't got postpartum, right? And so we have to use a different type of language, right? But we know what is being said, but it's like, baby, postpartum means just after birth. That's, you know, but we realized the disconnect because we were like, why aren't people coming to our postpartum support groups? Right? And for us to know, but we had to remember that that was a disconnect. So we have to think about that as well. But to be able to have sight to really see, to also understand, instead of condemning someone who didn't go get the services that you recommended, how do I help and support you to help usher you to get the supports and the services that you need? What is that disconnect that's happening there? And so I think, again, we start to cast blame on individuals as opposed to really seeing, you know, the work. I mean, as when I was teaching in Philly, I would always say, because I had a teacher says to me, it's like, you could get upset at a student saying like, why isn't Kareem listening? And it's like, what am I not doing to help him listen? And so I think we have to get to the place of like really, really reframing, to your point. And if we get this right, if we really do the work of serving and supporting Black folks, Black birthing folks, this helps everybody. Like everybody. Anybody else? See, I felt it.
I was wondering, what type of education are the moms getting? Like, I don't know, what is the limitation of what type of education can the doulas give them? About, you know, their medical conditions, what to expect? If you see this, is there a limit, or how does that work on the doula's end as far as the education to the mom? Because that would definitely help support if she had that education about what, you know, it's something you said and I can't remember what it was, but the education would really help, you know. This is what to expect as far as, you know, like postpartum, you know, preeclampsia, gestational diabetes. Because if we know the provider's not doing it, so what how does the doula support educationally wise for the moms?
One, every doula is different, every practitioner is different. So I would say I'll speak from myself or even a Bloom perspective, like our postpartum support groups just start at the minimum basis of humanity and start from just wanting to be in relationship. And once we've done the work of cultivating the relationship, it is really where guards are down and people realize that you really care about them. From my vantage point, there are things that I think I know about a good amount of things, but I know I don't know everything. So we have our midwives, we have our therapists who come in. Sometimes we're just making candles with one another and we're just being a level of support. And really what we find out is that sometimes people just want community. Also in the postpartum period, particularly folks who are thinking about lactation, it's just a real quick answering of a question that totally like decreases stress because there's a high level of stress with lactation for those folks who chose it. But again, I think everyone is different, but the intentionality is to first meet you from a human to human relationship building. And then how do we collectively get you the answers or get you the resources that you need? Sometimes a lot of times people think community-based work means that you're only helping people who are unemployed, or people without funding. We have doctors all the way to folks who are unemployed, but no one doesn't know unless they have told their story, right? And so this is happening to everybody. And what it really does is it demystifies the hierarchy and it really just puts us back into right relationship with each other.
I wonder if there should be a prerequisite for every woman that gets pregnant, that she has a certain amount of education of what to expect, how to be treated. I mean, I know I'm going way, but education is so important. And it's something you said, I can't remember what it was, but if the mom was educated, she could advocate better for herself. She'd be more confident during this pregnancy.
Yeah.
The knowledge, I think, and education part would be very important. So, and I know you have the midwives, but something on a more personal level, maybe.
Yeah, I mean, so for us, like, I'll just say we just last week ended our like childbirth education. Is like a 3-week course. So the two facilitators was Dr. Lauren Arrington, who's one of our advisory board members, and then also Stephanie Etienne, who's also the co-founder of Bloom, both of them are certified nurse midwives. Lauren is a DNP, but beyond any of that, she was trained by Granny midwives for a very, very long time. And so that's her essence. But a lot of the folks who came to the class said, I thought I knew a little something about something. But now I'm kind of going in and talking to my OB and I'm like, but what about this? What about this? And I got a birth plan now, right? And so what it does do is like, it's not like educating as though we're putting something on, it's a learning with that then gives or is like we're empowered together, like they're already powerful. And now we're trying to help give you the tools to really start ushering into how you want to birth and how you want to do this work. Yeah, and I think it's something to think about if you want it to be medicalized, like, or if you want it, like, to give options, I think is also around autonomy. So what is it that the hospitals can offer? And then how can the folks within the hospitals or the other clinics can say, what are the other communal resources so that you have a well-roundedness to be able to make the decisions of what might fit for you? You might be Muslim and might be looking for a Muslim childbirth education class that you might not get in a particular hospital setting because there are some particular like cultural connections that are there as well. Yeah. Okay. Yeah. Okay. Thoughts and ideations.
Hi, good morning. I just wanted to take a minute because I couldn't help myself but to talk about the Centering Pregnancy Program, which I know was mentioned earlier. I work at Mercy Medical Center. I'm here with my colleagues, and we started our Centering program a little over a year ago, and it's exactly what you're discussing and asking about. It's education, it's support, it's comprehensive care, it's midwife-led. So they're learning about comorbidities like hypertension, diabetes, anemia. They're writing birth plans. They're learning about medications that are available to them at birth. And we're also really teaching them how to advocate for themselves when they are giving birth. And then a while ago, earlier this morning, there was a question about fathers and partners and their role in it. We have seen such a huge difference in the partners that attend centering with their partner, with the pregnant person, and their engagement and their knowledge, and just hearing them say, I never knew what my wife or my girlfriend was going through until I came to these classes. They are here for 2 hours, so it's obviously a lot longer than a traditional visit. And they usually see the same midwife for each session. There's a total of 9 sessions. So I just always like to take an opportunity to promote centering, make sure that everyone's aware that it exists. And if anybody here is from another Maryland hospital organization that doesn't do centering, I encourage you to ask about it, because it's a fantastic program.
Awesome, thank you. Dr. Keisha Baptiste Roberts, and then also Lauren, and then this young woman in the black, yes. Listen.
Thank you. Tanay, I just wanted to go back to this slide about obstetric racism, because I was having some conversation with my husband about this term. He's an OB. I just wonder what your thoughts are, given what's going on with DEI that's become a bad word. And we've seen some things here in our city with health systems. How do you think that we can really address this? Because initially I was thinking, okay, this would go through the DEI office, in a health system kind of setting. But now that that's sort of being, well, first of all, that was great initiative, great thought, but usually underfunded and under-resourced. As a department division, it's usually one person. But given that that is sort of being restricted as far as what they can or cannot do, or what's acceptable, how do you think we're gonna address this?
Well, I will just say that Donna Iene Davis really speaks for herself in her article, and also to what the sister was saying back here, the Prim OB scale that Dr. Karen Scott, those things combined, they've already kind of like wrote out what could happen and what has already happened. But what I would say is that I think just in general, we don't really want to contend with racism, right? So it's like every single thing that is happening, whether it is mental health, if we're thinking about Black folks, if we're thinking about preterm birth, at the root of any of those things is racism. And the body's responding to that. And I think there's something about people having to come to terms with that, because people are literally dying and there's morbidity. But I will say that I don't want to speak for Dr. Donahue, being that she coined the term, but she wrote the whole thing of what you could do with it and what should be done, and has been very intentional about being a voice, and hospitals have brought both her and Karen in to be able to do a lot of that work. So I think if you go to, I won't say a lot of hospitals, there have been a few around the country, okay? There've been like four. And there totally could be more. I am being a little funny, but I think the other part of that is similarly to the conversation around grants. It is saying we also don't need you all to see us, but we need you to understand us. And what I mean by that is that they're going to keep on doing the work. And because what is going to keep happening, because collectively around the country, we're not actually doing the work that needs to be done, it's going to continue to make manifest. And it's going to be one of those things where years will be like, we told you. Right? So I think the more noise that is being made, the more writing that is happening, I think that folks are starting to realize this is really it. But I want to be careful of that, is that Donna and Karen would never say this is the total answer, because they totally understand that there's a constellation of people who are doing amazing work. And I don't think that really answers your question, but I think going to the article that both Donna Iene and Karen wrote together around destigmatizing postpartum care, and also going to the Prim scale, the Prim OB scale, and then also the birth story here, and Dr. Donnie Davis's book, Reproductive Injustice. I think those things combined really give that answer.
Good morning. So these are all very complicated issues, and I could probably talk for 6 hours about it myself, but thank you so much for bringing them up. But I just wanted to put a plug in for preconception counseling, because I think we start too late to educate women about their bodies, whether from when they start their periods, even, or schools need to be doing a better job. That's a whole nother conversation. But really educating them through the process and talking to them about what do they think about when they want to get pregnant and what does that mean in terms for themselves?
Was that a question for me? No, I think you made a statement, right?
That was just a statement.
Yeah,
that's
that's
all.
all.
Yeah, I
Okay.
just wanted to put a plug in because I think it's so important that we just
Yeah.
wait so long and then we throw all this information at women at one time. And I think we need to start preparing them when they're younger.
Yeah, absolutely. Mhm.
Oh, okay. Sorry, I just wanted to piggyback earlier on the centering pregnancy program. There's also centering parenting in pediatric offices, and that's the mother-baby dyad. And you can include doulas and social workers and people rooted in community who know the resources already in those programs. And there's not enough. Okay, thanks.
Thank you, Lauren. So y'all know this is your Q&A chance, right? Y'all done took it all up. I'm just joking. So really hope to bring this all together that really, again, when we're thinking about the words that we use, the intentionality behind them is that really reproductive justice encourages us to practice building a new world, a different model that centers people and not systems, to really challenge those systems. I wanted to just uplift during the Maryland Black Perinatal Health and Reproductive Justice Summit, Dr. Tanay Lynn, there were 2 points that, or really 3, but there were a few things that like really stood out. And she put, as she's also a medical anthropologist, she mentioned that from her studies that there has never been a time when Black women's reproductive needs have ever been addressed appropriately. And a lot of folks were like really sitting with that, you know, like we knew it, but it's like, dang, like never. And then at the end, she put, if medical systems are aware of the outcomes it produces, can we rightfully claim that they are guilty of eugenic practices? And so I think that there's something about the reframing of questions that they're hard truths, but they're truths that we have to contend with to really get us to, it's like putting fire up under us all collectively as a collective body to be able to start thinking about doing this work of change and transformation. And then Karen Scott had mentioned, just because you don't see the pathology doesn't mean someone's not being hurt or harmed. And then she said the issue is that hospitals in the US do not routinely keep Black women, girls, and gender expansive people and their loved ones safe during pregnancy, birth, delivery, and postpartum. The current system prioritizes being safe over feeling safe and feeling whole and dignified. And so she puts that the solutions are new ways of defining and measuring patient safety and defining feeling safe through patient experience. And so that's where she creates the pre-OB scale. And then she puts, we must call out the lie in quality improvement. The absence of perinatal pathology is the presence of perinatal equity. And Adrienne Marie Brown put, liberated relationships are one of the ways we actually create abundant justice, to understand that there is enough attention, care, resource, and connection for all of us to access belonging, to be in our dignity, and to be in safe community. And so I think this is really an opportunity. We're thinking about convening space here. How do we be very intentional about the relationships that are built? You know, thank you all for even creating, this is a container, right? This is one container of being able to create the conditions. And so I think that there's something around us being more connected. Who are you? What is the work that you do? How can I learn more about you? How can you be a referral or a resource to the work? And how can we be more connected? Are really important moments of change and transformation that we really need to lean into, because we have so much resource here. Me and Donna sit as co-chairs of the Maryland Maternal Health Improvement Task Force. And one of the things that we've always said is that there is so much fragmentation, and that fragmentation is leading to duplication, and then that duplication is leading to wasted time, talent, and resources, right? And so I think there's so many people with great heads and hearts, but we don't realize that if we leaned into getting to know each other, what is already out there, what's happening, and how can we be in better relationship, that's really where it's going to stand the test of time. And some of the things that we often talk about with as our team is Divine Bailey Nicholas, by way of the Granny Midwives, we really center a few things. Like first, we center community, we center having character, the commitment, and the competence. And this is what we talk about as a team, and even with our colleagues that we're working with and learning with, is how do we really center these 4 Cs? How are we rooted in community? And that also is a recognition that we can be in community. I can see you, but that's also a reality that we also might not be in alignment, and that's okay. So not every single community-based organization is always going to partner for various reasons. Sometimes the ethos is different, and sometimes people have tried, but that doesn't mean that they don't recognize the value. But don't try to always push that just because folks are community organizations. But there's power in community at the same token. And remember, relationships build at the speed of trust, right? It's not money, it's none of that. A lot of people use money and resources as kind of the way through with relationships. But if you actually center relationship building and cultivation, they stand the test of time all the time. The character, commitment, and competence. How do we know what we know? And that's all I got. So I know I joke. Oh, there's 6 minutes. There's 6 minutes. If anyone has any other thoughts, questions, or reflections. Yeah.
Tanay, I've not been to a presentation that was more engaging. It was absolutely wonderful. A concern I have is that with all the emphasis on Black maternal morbidity and mortality, there is a rising tide of fear among Black women to become pregnant. And what we know from epidemiology is that in terms of the proportion of this population, we're the only group that's decreasing as a percent of the population. And then when you have this fear piece moving forward, it really is troubling. So my question is, how do you think we can, and the other issue raised about how funding is tied to dysfunction, unfortunately. How do you think we could begin to walk the tightrope between adequately approaching the issue, but not allowing this fear narrative to take hold and really take off and cause harm?
Yeah, so what comes to mind with that is in 2017, when we were together creating Black Maternal Health Week as a group, and then it was implemented in 2018, with all of the events that were put together nationally, like film screenings, the feedback is that what was unintended was we actually created more fear. Where it was, and for some of us, the goal of Black Maternal Health Week was more about a celebration and to honor what we've always done. So for many of us, we don't even talk about why we're dying. We talk about the solutions that are already in community. Folks are having fun screenings, and there's music, and there's joy, and there's yoga, and there's, how do you cook meals together and be with one another? But I think that there's something that we have to contend with where others have taken something and repurposed it for monetary gain, and have taken that week and just Black maternal health in general, where it has become a moneymaker. There are people who have come from the wazoo. One, and I want to be very clear with this, the creation of Black Maternal Health Week was never, or even the Black Mamas Matter Alliance, was never to say that we are the people. It was intergenerational to bring forth collective bodies of knowledge. So the folks who've been talking about this have been talking about it anywhere from 5 years to 60 years, right? So it's that convening, but it has become a way and an anchor for people to take its intended purposes for their own self-political and financial gain. And organizations have more so talked about the problem, have overly exacerbated the problem, but have not put any type of adequate funding into the solutions that are already there. So there's no funding that you really see for services in community. There's more so how you talk about it, and then how do you create higher levels of pathology and anti-Blackness within our own communities. Solutions, I mentioned that as a way for folks to think about it, and I think maybe I don't know, I think that's a collective answer of what is a solution to be able to combat that. And I think some folks just need to know that you've totally repurposed something that had an intentionality. And you have used it again for your own political and organizational sustainability, and have left out the folks who are actually doing the solutions. Thank you. I told Adrian I'll be like, there's 1 minute. Is that it? All right, thank y'all.